special speaker today. It's Dr. Hillmer. So I'm going to go through this briefly.
You can paraphrase.
It's a very extensive, successful bio. As most of us know, Dr. Hillmer is a director in the Strategic Policy and Planning Division. He's been part of the Ministry, Ontario Public Service since 2007. He's been involved in many exciting projects. Some of those is actually, one of those that actually really kind of caught my eye was including developing the chronic disease prevention and management strategy, and also creating guidelines for multiple sclerosis care. He has been awarded many awards for his excellence in work, and some of those include the Ministry's of Health ACE Award. Then there is from the Ministry of Children and Youth Services Pinnacle Award, and 2 Amethyst Awards for the Ontario Public Service, I believe, as well. And in his current role as a director in Research Analysis and Evaluation Branch, he actively seeks to ensure that ministry decision-making is evidence-based. He also fosters knowledge translation and active participation between the decision makers and researchers, which sometimes can be a bit troublesome, and there are issues to solve. And he also works very actively to accelerate adoption of innovative technologies in the healthcare system and complex health interventions for different chronic disease management. Before coming to ministry, he was also part of the Health Council of Canada. He also worked in Sandbrook Hospital General Internal Medicine Division, and most of us also knows him as an assistant professor at HCME, where Michael teaches courses and also participates as a guest lecturer. So it's a special pleasure. And as a tradition at THETA, THETA rounds, we usually introduce ourselves also and where we come from. So I'm Alrek. I'm Associate Director of THETA and also Assistant Professor at USP.
I'm Alexandra. I'm a Senior Analyst at THETA, and I'm a PhD student at the Institute of Health Policy Management.
You may take some of his courses, or you already
did. You're welcome to do it. You can get a preview and then decide.
I'm Nitha. I'm a research associate here at THETA, and I'm a master's student, and I actually heard you speak last week in one of my classes.
Oh, great. Okay, well, some of it's the same. I'm sorry.
Furthermore, decision model center. I'm also a assistant professor.
Yeah, great.
My name is Kaylin, and I'm a research coordinator at the program at the hospital. I also work as a knowledge broker for the course on prevention care.
Great.
I'm Anna Sarukiska-Hart, and I'm a health economist. I work in the Institute for Health.
I'm Better Kusanu. I'm a health economist here at THETA.
Hila Sahayan, research associate at THETA.
Also, I'm IT architect at THETA. Brian and PhD in pharmacy also.
Myra Wayne, certified genealogist.
So, Mola Carrot. In civilians, a PhD in the clinical science and
Amanda Day, master's student for social medicine. She's born in
American
I'm Nicholas in Vice Education.
I don't know if I'm like teaching students here at ISM, and I'm Michelle Timanin, and teaching manager, leading a project, and certainly how I can.
I'm Navish. I'm a PhD student at the graduate course. Brian Falkenberg, I'm an associate professor here at Pharmacy.
Great. So this is great because we've already accomplished one of the key central tenets of knowledge translation between policy and knowledge production, and that's just getting to know one another. And as cliched as that sounds, that's what the science says is the most effective method to ensure your findings end up in policy, and that policy ends up being evidence informed. It's about relationships and networks and trust and understanding of vocabulary. So this is a story today of knowledge translation, of evidence, of two solitudes of the research community and the policymaking community, which I think in Toronto's case in the Ministry of Health is much, much closer than anywhere I've seen in Canada, most places in the US. The physical proximity helps, and our programs academically end up populating a lot of the places that I heard are here today: Public Health Ontario, the Ministry, Cancer Care Ontario. So that two-way line of communication and travel is open and free, which I think benefits this province enormously. So I want to thank Val for the opportunity to speak. I have known Mert a long time, and Val, I'm getting to know her much better, and I work very closely with both of them on a project that I think is a parable in a lot of ways for what I'm going to talk about. It's an enormously complex innovation with so many moving parts, and it shows you why the evidence is the starting point, but then you move into the art of the implementation, and it's really the science and art of getting knowledge into action. So the first thing to know about policymakers is there's always a vocabulary, and that vocabulary changes. So right now at the Ministry of Health, these are our guiding challenges. So you're going to hear every single policymaker talk about the enormous fiscal challenge, and that results from two trends. One, that health had historically in this province been growing around 8% per year. That's now down around 2%, which is a Western world phenomenon, and nobody's quite sure how long that will continue on. And then the enormous structural deficit that has come from both the 2008 crash and this province not necessarily having the same kind of economic production that it used to. So those two together mean that all ministries, and health in particular, are facing big fiscal challenges. Demographic challenge, StatsCan just tells us there are now more older people than younger people. I mean, this is nothing new to any of you, but it's important that the words that get used to frame those challenges, and in turn, that's the words and the themes you'll have to use to frame your work in to ensure that it has resonance with the people you're talking to. The risk factor challenge that we all know about, and then an interesting shift in health policy thinking is around the segmentation of populations and the specific models of care that can support those segments. So no longer do you have huge general application models that are thought to fit everybody, but you have models like HealthLinks that are specifically designed for the people who use the system a lot, complex chronic disease, and could probably benefit from better coordinated care. You see not that long ago the introduction of integrated funding bundles. So bundling a surgery plus the home care plus the rehab in one funding pot, and letting one lead architect design it all and be accountable both for the funding and the outcome. And underlying all this is a shift more and more to value-based payment. So these are all dominant themes that form the mental model and the way in which policymakers in the Ministry of Health in Ontario are interpreting issues and problems. So more of the same in that just the demographic challenge alone presents, you know, huge potential dollars invested over time. The minister's action plan, this is the action plan 2.0 that Minister Hoskins released back in the early part of the year. And again, these are the ways in which we filter issues and problems. And, you know, if you're unable to demonstrate you're aligned to one of these themes or the projects that sit under them, it's not that your findings won't find their way into action, it's just you're going to have to work that much harder. So Jonathan Lomas is one of the seminal thinkers on building evidence into policymaking, and he created this schematic that I think is a good one because it shows that there's an iterative relationship between the, you know, those who are producing information, both, you know, you as academics, but then also how that information is packaged by journalists and popular media. And, you know, that the theory goes is that information will persuade people to change their belief about what causes what. It will not change people's ideology, views about what ought to be. And then the other piece of the value construct over there on the right are the interests, and you know, these are the stakeholder groups and their various relationships with each other and with the government. And so, but however, that value construct can then drive what kind of information is produced, because it determines what granting agencies put as their funding priorities and what ministries and governments talk about as their priorities. So that iterative, I'm not sure I said I would entertain questions, Paul, but for you. No, I'm kidding. Yeah, please. I'm happy to. I would like this to be interactive, so please.
So I'm wondering which policymakers are we talking about in terms of? So this is the framework over here.
So this is, you know, this is a general schematic for policy making, and I would say this is any, you know, Westminster model.
I see.
Yeah.
You have to wonder sometimes.
And so the thing to remember too is that there's what hits the agenda, and it is generally the political structure that determines that, and the bureaucratic structure are the people who suggest how that set of objectives can be achieved. And so this is more around what hits the agenda. And I'll show you more of the process for how me on the bureaucratic side would go through the process of determining how that could be achieved.
Yeah, my thought was in some contexts, see decision makers or politicians at least seem to be willfully ignorant of some facts, right? They choose not to believe it.
Well, I mean, but I think that goes to ideology and beliefs and interests, because they're separate things. So I'm not going to make any comments about any particular politician, but just to say that I think this illustrates the point that, you know, ideologies don't tend to change. So, you know, if that's the schematic, and there are lots of different theories for how that first schematic happens, and Jonathan Lomas is, you know, he's got one take. This, however, is the policy roadmap that the Ontario Public Service puts forth as, you know, these are the steps you should take when you're developing a policy. So, you know, the initial problem statement is usually presented to you, you know, either from the political platform or from the budget statement or from the throne speech. That agenda is usually set at a very high level, you know, negotiation between the minister and the premier, or the deputy minister and the minister and the premier. So that's that political construct that sets the agenda. And then it's given to us on the bureaucratic side, what's the best way to implement that? And that's where we kick into gear with, you know, what does the evidence say is the best way to do this, and what do we know about the system we're talking about, and you know, how do we come up with objectives? And you see, I mean, this is not unlike the steps you take for a research study. You know, you got to understand the problem, you know, marshal the evidence, you know, design your study. In our case, we design options. We present those options to the minister. The minister selects which one they think is going to be the most palatable, and we do our best to weigh the pros and cons of any particular option. And what comes next, once you have that recommended option, is depending on what you're advising on, whether it's a new policy, this could be a program creation or expansion or elimination, a new government policy, or anytime the government goes out and does a consultation. So right now, there's a consultation on that the Associate Minister is leading. Actually, it's a parliamentary assistant, on dementia and aging. So they're going around Ontario talking to citizens to get their values and their perspectives on what the system should look like for dementia care. If you're proposing new legislation, or if you need any of those initiatives require new funding. So any of those, so that's a pretty broad set of activities. So for the most part, anything new we have to do, we have to go to cabinet. And that is a whole separate process. And that's often why it takes a long time to get stuff done. So what happens is, you know, so that if that first schematic is how the policy agenda gets set, and that, you know, stylized P is where the policies get developed, then you move into this legislative process. So this column here, there are a series of committees that are comprised of MPP, and so all of our work would go to Health and Social Services Committee, but so would Education, Community and Social Services, and Children and Youth Services, and they're the pre-adjudication committee before it gets to full cabinet in that policy approval column. And lots of iteration can happen there. And this is something interesting too. So, I mean, most of you would think of the Ministry of Health as one of your key stakeholders, but there are other important structures within government too. So sitting here is Cabinet Office. They're the Premier's ministry. So Cabinet Office they're the group who are the air traffic controllers for all the submissions going to Cabinet. And one of the messages I'll talk about today is that you have to think about systems and how those systems interact with each other. And frequently researchers think about their little silo, and you know, we encourage them, well, you got to think about how your initiative will interact with all the other initiatives out there. And it's not like your initiative can just be planted into, you know, until ground. There's a whole system out there which has to nest within. So the people in Cabinet Office, they tell the individual ministries, like, well, your health initiative isn't the only thing out there. And in fact, what you proposed actually jeopardizes what education is trying to accomplish, what children and youth is trying to accomplish. You know, maybe the IT architecture you're laying down will completely hamper some flow of information that will, you know, a case manager would need in community and social services. So they bring that macro view. So, you know, think of a series of nested Russian dolls that, you know, we sit within a very complicated, interrelated system. And that's one take-home message that I would want you to walk away with, that you might have a great piece of evidence on how to optimize one piece, but it might not be the way to go, even if it does optimize that one little slice. So, Paula, this is a slide that talks about your question. I mean, so there are lots of users of research and evidence, but I wanted to focus particularly on the government users. So you don't think of us as a homogeneous block, because there are the ministers and the people who work for them as one potential consumer of evidence. And you know, you'll have the whole range. So I mean, our minister now and our previous minister, Deb Matthews, were great champions of evidence and wanted you to bring it forward. And for people like me, it was an amazing scenario to be in because they were welcoming of it and encouraging you to bring forward evidence. But then there are the people who are on the backbenches. They're part of the ruling party, but not sitting minister. And then there's the opposition. So John Lavis, who's one of the great knowledge translation experts at the policy level, co-wrote a book called Paradigm Freeze. And he came to the conclusion with his co-authors that you don't go with the sitting government. You start forming relationships with the opposition, because the most progress happens in the first 2 years. And if you have formed a relationship with that party that will come in, you can have a whole range of hopefully really well-informed policies by evidence that are ready to go with all that 2-year momentum. So it was an interesting perspective that or conclusion that he drew from his work. And then there's the civil service at every different level, federal, provincial, and municipal. And health, the federal isn't quite so much important for delivery, but it certainly is for funding and, funding at the macro level, whether it's the transfers or funding for research itself. And depending on the kind of research you're doing, municipal politics is maybe where you want to be at. If it's, about built form or housing, municipalities are the ones who are responsible for that kind of activity. And this is a slide from the knowledge translation course I teach, and it tries to separate out, the different levels at which evidence gets used, the kinds of evidence, and then the format of the evidence. So instrumental evidence, that's the classic randomized control trial that says drug X is better than drug Y in these scenarios, and you can go and act on that right away. So when that patient is in front of you, it's clear that you should give them this drug because this RCT said it was more beneficial than anything else. There's a direct application of that evidence. Whereas conceptual evidence, it's not direct. It's either from a different jurisdiction, or it's from a related field, or it just is suggestive of a trend. You can't use it right away, but maybe it forms the way you're thinking about an issue. And so practitioners, they're frequently using instrumental evidence. Policymakers are frequently using conceptual evidence, because it's not that randomized studies can't be done, it's just they're not done that often in policymaking. So there's not often that nice randomized base to look to. And there are lots of scientists out there who are actively trying to change that. And so you're frequently looking for that, that best match case of the conceptual evidence. And then sitting in the middle are organizations who are setting organizational policy, or regional health authorities, and that's a bit of a blend. And this is not empirically derived, it's just my observations over many years. And then you see the kinds of evidence. So, practice guidelines and Cochrane reviews, and to date, those are the kinds of places practitioners go. And then where we might go are places like Health Systems Evidence, which is a database that John Lavis maintains, that he says contains every system-level meta-analysis, systematic review of health system intervention. So how systems are financed, how they're organized, how they're governed, how the delivery structures are set up, as opposed to how to deliver care to an individual.
What is his framework suggest about the current operation of the Ministry of Health?
He just collects the evidence. He would say that we don't have enough formalized mechanisms to build evidence into policy that are transparent and routine. And so that's part of my job, is to build those mechanisms. And I'll tell you about a few of them, but he would say they're not enough. And he wants to push the envelope. So I'm just going to compare to a familiar paradigm to most of you, that of evidence-based medicine, to that of evidence-informed policy, because another take-home message is that policy making, is slowly starting to become a science in that there is a, there is an empirical way to go about developing policies. I would not say that we're there yet, but it's emerging. And so the parallels here are that, the classic set of 3 domains in evidence-based medicine are the best external evidence you can find, the patient values and expectations, and then the individual clinical expertise. And in that middle is, that evidence-based decision that hopefully gets you the best possible outcome, respecting what the patient wants. In evidence-informed policy, again, you're looking for that best external evidence, combining that with what you know of the population and their values, and then your intuitive understanding of what the system looks like, what it can absorb, and how to go about implementing it. So again, a big piece on the individual built-up wisdom and expertise of the policymaker, and in the middle, evidence-informed policy. Both sets of decision-making paradigms are always bound by these limitations. You don't have enough knowledge, your information is not complete, and you don't have enough time. Equally true in both cases, whether it's a patient in front of you or whether you're developing a policy. And John Levis says, in the policymaking case, the best available research evidence is highest quality, most locally applicable, synthesized research evidence. Hopefully finding that instrumental use, so it's a perfect match. Somebody's done the study in Ontario in a site or a region, and you're just going to scale it. And then more broadly, conceptual use. Like you might think that activity-based funding is the way to go in Ontario because it's been demonstrated to have good impact in other countries, even though you're not going to implement it quite the same way, and you're not sure if it's going to work quite the same way because those other systems are designed and organized differently, but that's the conceptual use. So, and what do we know about the ability to influence policymakers? And so here's where there's a big difference in what we know of provider behavior, which is still an emerging science, versus policymaking behavior. It's very easy to study the changes that happen in a provider's behavior because you can measure, how patterns of prescribing changed or outcomes that changed. And of course, that's still challenging, but not near as challenging as figuring out what might have changed for a policymaker, because there's so many factors that impact what, the advice that I give and what happens to it. And so you have to rely on things like intent and behaviors, and then you're frequently limited by the fact that what I do and recommend, I can never tell you about because it's confidential, and I have an oath that I took to keep that information confidential. So I might not ever be able to tell you how my behavior changed or what I did. So tough to study. But what we do know are that it's all about interactions and relationships and networks. And you can look at some of these citations if you're interested, to kind of dive into some of that a little bit more. And it's all about the timing and the timeliness. And that's so, and they're not mutually exclusive. So if you have a good relationship formed with, either a network or an individual, the timeliness takes care of itself because you're comfortable picking up the phone and calling that person and just looking for some informal advice. So if you are interested in having an impact as an academic and at a policy level, I encourage you to start forging those relationships. And again, you're lucky to be in Toronto because there's a good chance that the senior faculty in whatever department you are have some of those relationships that you can start trading on. So I'm going to give you an example of why it's challenging to implement even the best, highest quality evidence. So a while ago, I'm not picking specifically on Sharon Strauss here because I think enormously highly of her, and I am a co-investigator with her on a couple projects, but it's just a good example because she sent it to me, and she said, Mike, you might want to be interested to read this, because it's, you know, you're doing initiatives like that now. I mean, you're interested in reducing the readmission rates of high users, and that's what this meta-analysis is about. So frequent users of healthcare services, small group of patients account for a disproportionately large amount of healthcare utilization. So the systematic review of the healthcare interventions you could put in place to reduce the readmission rates of these frequent users. And so they found that quality improvement strategies for coordination of care, reduce hospital admissions among patients, you know, with chronic conditions other than mental illness, reduce ED visits. Our results may help clinicians and policymakers reduce utilization through these strategies. And they were team changes, case management, you know, at the kind of team system level, and then patient self-management techniques for the patients. So I'm going to ask you to think about it from the perspective of a hospital. So first of all, if you know, for those of you who are in hospitals, you know, who's the decision maker? Who would even decide to launch this? Would it be the CEO? Would it be the physician in chief? Would it be the nursing manager? So right off the bat, it's not even clear who would launch the program, and it probably changes from hospital to hospital. So once you've got that figured out, who's going to implement it? I mean, is this a nursing-led intervention? Is it an allied health, or is it you know, some corporate executive where you're going to bring consultants in? So again, you know, the meta-analysis doesn't tend to address these contextual factors. So let's say you figure out if, you know, what team's going to implement it, and is it going to work in my institution? You know, I am in a small community hospital. Most of my physicians are having local practices where they just come in and staff the ED when they're not in their clinic. And we chronically have to use agency staff for our nursing. So, you know, so maybe, even though on average it works, it might not work in your institution. I don't know why. I wasn't supposed to change color. That's not indicative of anything. Other than, I think I grabbed it from another slide deck where it was orange. And so, and what do you need to know about the intervention? Because you talk about team change or case management. You could imagine 1,000 different ways to implement that. And, you know, maybe you'd even try to go back to those individual studies to see, I'm going to try really hard to be as tight to those original criteria, but I would wager that those original studies don't give you anywhere near enough information to tell you about how to form the intervention itself, because what happens in a research setting can almost never be replicated in real life because of resources and presence of a research coordinator and you know, the incremental funding that usually comes with a research study. And so just to drive home the point, you know, here's the, you know, they do provide some of the definitions, but they're still pretty general. You know, if you're talking about promotion of self-management, what paradigm are you going to use? What materials? You know, because you get right down to that micro level, and you have to decide those things. And maybe if you use the Stanford framework instead of the Lorry framework, it's not going to work. You just don't know. And so I'm going to skip that. And here's the limitations. You imagine going to a policymaker, a hospital decision maker. We don't really know how much of this intervention to give, or for how long, or how often. There wasn't really good definition of who was in and who's out. We don't really know if the intervention worked because the concealment was inadequate and there might have been systematic bias. The QI strategies were complex, interconnected, and difficult to classify. So it wasn't even clear what the mechanism of action was. We couldn't control for all confounders. Lots of heterogeneity, no contextual factors, and they didn't have cost. They couldn't even tell the decision maker what they might have to pay for this. So, you know, and that's the gap. And that's what we face as policymakers when you bring us your best evidence that doesn't include this. And it's not that you have to include this, but we'll have to go through this exercise. So if you're able to include some of this, it's going to be easier. Yeah.
I totally agree with some of the things that you pointed out. But do you think that a meta-analysis is the most appropriate channel to address all of these questions or tools?
I don't, but in this case, you know, I don't think I'm telling tales out of school. Sharon sent this to me and said, you know, thought you might be interested. And so if it's not here, I don't think there is a place, not a systematic place where this stuff is. So right now, a policymaker goes through these questions in a, I would say, an artistic way. I mean, you can come up with answers to each of these in a rigorous way, but you have to go to different sources, and you're often computing or trying to figure out, based on your best estimate, what this might cost. And all I'm saying is if somebody happens to come along with a competing intervention that happened to have done this, you know, all things being equal, I'm going to go with the one that I don't have to do all those things with. And it's never that simple, but these are things that inhibit knowledge getting into action, in my experience. Yeah, Patrick.
And sometimes this is the problem with evidence-based information, so that evidence also is what is the absence of evidence of some of the things. And I mean, if the ministry is willing to take an evidence-based approach, then understanding what the gaps in evidence is also very important to fit. And the alternative to this could be a decision that is not based in evidence, where these limitations would be potentially ignored.
Yeah, so I think the advantage of this meta-analysis is it says, you know, conceptually, if you start launching QI strategies for frequent users, there's at least a reasonable expectation that you can improve their outcomes. Exactly how to do it in a particular hospital, we don't know that yet, and that's a gap. But you know, it's not to say that this is a statement of not doing it, but it's clearly a gap because you could implement this in such a way where you'd see no effect at all, and that would be a shame as well, when some of this information could have easily been collected and published in an appendix or just available. Health services researchers rarely think of contextual factors, but it wouldn't be that hard to start collecting that. And you know, if you are launching studies and want some advice, you know, I would say, you know, I've worked with THETA now pretty closely, and I think they have a, you know, you work for THETA, you have a better understanding of contextual factors than most, which I think it will serve you well because you can implement complex innovations more effectively. And so that's why I say it started, policymaking starting to emerge as a science. What's the right way to capture contextual factors? You know, we know leadership is important, but what does that mean? How do you capture that in a reproducible, transparent way? And you know, if there was a way you could do that just by asking a couple of questions that had no net incremental add-on other than a little bit of time, then I would say that would be a good investment of your time. So I'm going to just flip through that. And so, you know, that whole exercise just shows you, and you know, that's what will go on in his research said, it's the century of the system, and unless you think of, you know, we're collectively implementing all the time complex innovations that need to be thought of in a more of a system perspective rather than an individual intervention acting in isolation. And so, you know, he wasn't the first person to come to this realization. And one of my favorite authors, Tricia Greenlaw, has this very comprehensive model that she derived in 2004 from an article, Diffusion of Innovation in Service Organizations. And you start looking at some of these domains, like, you know, the adopter, and you start seeing, you know, and this is what a knowledge broker thinks about, right? You know, what are the needs of the person, what are their motivations, what are their values, what do the social networks look like? You know, some of these things that seem like soft, qualitative pieces, but, you know, the human resources, the dedicated resources, they can, you know, if you haven't thought about those things, your intervention will never scale. And the funding we put out, we put a big emphasis on the knowledge translation plan. So you have people on your team who can tell you about these things. And I would never say that you have to become an expert as an academic in all these things, but you do need to form alliances with policymakers who are experts in their own field who can tell you about these things. And that's the theory of integrated knowledge translation. So I encourage you to take a look at this article. It's a fabulous article that really takes a huge amount of literature and distills it down into some very interesting findings around how innovations can be diffused. And it's a big, long article, and if you're interested in a short article, Chris Tyler is an advisor to the UK government in the science office, and he wrote this nice piece around the top 20 things scientists need to know about policymaking. There's also a 20 things that policymakers can learn from scientists. So the opposite, and it's co-written by David Spiegelhalter, who's one of the great biostatisticians of all time. And I don't list them here, but it's interesting in his article. He says they're listed in no particular order, but his number one thing is making policy is really hard, and it's incredibly challenging to put forth a complex innovation in a system where you're not sure what the interdependencies are, and you're not totally sure what the outcomes are going to be, and you're trading off enormous things on the opportunity cost of using that investment in health versus education, and putting a complex innovation into a complex system. So it's enormously challenging. So I don't think anybody here in this room would ever think this, but there are scientists out there who think, why aren't you just implementing this piece of evidence? It's the simplest thing you can ever imagine. And that's the facile approach. It's just never had to see. And the 19 others are really good and thought-provoking and provide a nice level set the next time you go talk to a policymaker. And you can bring them the 20 things that they need to learn about you. So now we move to how the system can support the use of evidence. And this is focused on the ministry and the things that I do. Back to our policy roadmap and the particular functions that sit in my branch and how I try to start bridging some of these gaps. So we have a research unit that funds research. This is novel investigator-driven research that is deemed to be policy relevant. So it goes to a ministry relevance process and then a scientific review, external, transparent. And the only thing that comes out are things that, in that quadrant, high relevance, high quality. This is a slightly older slide. The unit is now called the evidence synthesis unit. They're basically a rapid response unit who can comb the literature, put together what I would call a narrative review with a nice, tight executive summary on whatever topic you could imagine for policymakers, so that they have the expertise and the training to find stuff quickly and systematically, and they prioritize finding those systematic reviews rather than the individual study, and ship it off to the policymaking team in as quick as a couple hours. That's the fastest we've ever done. We call that a rapid response. Lots of caveats. Excuse me. Or a preliminary literature review, which is over a couple of weeks. And then an economic analysis and evaluation unit, and we've got health economists and evaluation specialists and health services research types in that unit. And my chaperone, Eric, is a member of the economic analysis and evaluation unit, and he's a great example of a academically engaged policymaker because he maintains an appointment at the University of Toronto, but his day job is informing policy with economic advice at the ministry. So our Health System Research Fund is, I'm just going to do a time check. Okay. It's just based on this idea of a generative cycle that cranks around and generates evidence, builds capacity in the province in those areas where we think we need scientific expertise, supports priorities, and improves outcomes. moves around the cycle again and again, hopefully closing the gap each time. A couple of our specific knowledge translation initiatives. So we sponsor policy roundtables where we bring in scientists either that we fund or that are just prominent in the field, policymakers. We did one of these for dementia where we had some people from the Brain Institute, from neurologists from Sunnybrook and Western and London, and scientists from ISIS and policymakers and the Alzheimer's Society, and it modeled a little bit after the process that John Lavis uses at McMaster, where he has these deliberative dialogues and sort of a structured way to have people put their opinions out and have their, both their voices and their values heard. We have basically our annual research, or biannual, I always forget, is every 2 years. Is that biannual? Yeah, okay. There we go. Every 2 years, we have a research showcase where we ask all our funded recipients to come in and ask them to do a 2-minute pitch of their research. And that always causes great fear and loathing, but they get up there and they do a great job, and because they're policymakers there, and that literally sometimes is as much time as you have to make an impression. We ask everybody that we fund to come and do a classic lunch and learn. That's our research to policy dialogue. I would say our most effective KT mechanism are applied health research questions. So everybody we fund has to set aside 25% of their funding to respond to questions from the sector. It could be the ministry, it could be a Lynn CEO or a CEO of a charity, and so the question goes forth to the researcher, and the researcher might say, oh, you know what, we already know this, I'm just going to give you the evidence. Or maybe it launches a whole new study, and through that process you start getting that nice integrated KT, because the renal network, for example, asked ISIS to help them plot all the demand curves for dialysis services. Really practical, but also really interesting from a research perspective. And when it works really well, the scientist publishes a nice high-impact publication, maybe a new methodology, new finding, and then the user, like the renal network, gets a nice set of robust demand curves that they can use to build new dialysis clinics or not. The rapid response unit, since the mid-2000s, have done about 800 of these, and when they're good, they're fantastic. We did one on regionalization of healthcare services that I'm really proud of. It's a classic example. It's that conceptual piece. You're never going to find a study that tells you whether you should regionalize or not, because they randomized. But there's some clear signals that come up from jurisdictions that have regionalized, and it's interesting to watch, in different jurisdictions, the pendulum swing from regionalization to centralization, and that was a really nice one. And we do all kinds of economic modeling and analysis, either on a consulting basis, advice to build capacity, or we do the project ourselves, or we work with people like Murray and Val to develop it, so that we always have that cutting edge methodology built into our practices. I'm going to just end with a couple case studies that show how evidence makes its way into policy. So a few years ago, Therese Stukel, who's a fabulous health services researcher and biostatistician at ISIS, did what was in some ways a pretty conceptual piece by mapping out through the use of a loyalty index where what hospital did you typically go to, determining for the most part 80% or 90% of the time, did you go to that hospital and did you get most of your care in a locally defined network? And intuitively you would think that was the case. She was able to show it empirically that these localized networks existed in the province, as she called them, multi-specialty physician networks. And so it showed that there was this self-organizing nature of healthcare services in the province that had just happened organically. And so this happened right around the same time that Walter Wojcik and his health services performance research network was doing a lot of work on defining who the high-cost users of the system were. And anybody who's a student of health economics knows that this is not an unusual trend, and it's kind of what you would want. But there was a theory that those people in the 1% were maybe consuming a disproportionate amount of that, and if you organize their care more effectively, you know, you can free up resources. So now you have the idea that there's a self-organized network, and you've got a set of users who need their care organized better. So, you know, the confluence of those things roughly gave rise to HealthLinks, where you now have a policy initiative that asks those locally organized networks to come together, identify those high users, coordinate their care better using planning tables, where you'd have all the health providers and the social providers that come up with a jointly agreed upon care plan. And whether this works or not, that's what we're evaluating right now, because I think there's some emerging evidence to say that the idea of organizing your care like this can make a big difference, and I think that's from the ACO literature in the US. These are not ACOs, so I think it's an open question as to whether these will accomplish the aim of improving care and costs for these individuals. But you can see how, you know, those confluences of evidence plus the fiscal challenge gave rise to this particular initiative. Yeah.
Where does this initiative my quarterback, the person who is sort of in charge of the patient?
It all depends on the health link. So each health link has a lead organization. Sometimes it's the CCAC, sometimes it's primary care practice. And the lead organization spearheads the effort to identify all the people that might be eligible in that geography for the services, and then uses, you know, whatever means. If it's a primary care physician, they're the ones who reach out. If it's a CCAC, they use their method. So it's one challenge of evaluating this is that, you know, every health link is a bit different. So it's not clear that there's one specific mechanism of action other than you're organizing care more efficiently. If that's, you know, I don't know if that's the same mechanism link, you know, health link by health. But so another day I can tell you about how we're trying to evaluate this. That's an interesting project. And then I just wanted to show you an example, you know, where there is at least some empirical basis to think that we can make a difference. So the Center for Medicare and Medicaid Innovation, CMMI, in the US is doing a lot of really cool stuff. And so they evaluated the pioneer accountable care organizations. And these were the roughly 30 organizations in the US that were deemed to be the most ready, the most sophisticated organizations who could start accepting the risk of taking a per patient payment and organizing all their care, primary, secondary, acute, for that payment, and accepting that they might lose money if they have to pay more for that care for that patient than the payment, or whether they could gain money. And so the group at CMMI showed using an adjusted difference in difference model that, so the circle and the triangle represent year 1 and year 2, and then the x-axis is the dollar amount per member per month savings over similar patients not in that model. And what they showed was, depending on what geography you were in or across the board, there was more savings in some cases year 1 than year 2. You seemed to lose some savings, but then there were certainly some ACOs that lost money. They had to spend their own money for those patients. So again, not a panacea, and it also shows you how complicated it is to try and make a difference across a system where everybody does well. But it's also an example of where this is a directly relevant piece of evidence that was published in an incredibly high impact journal. So you can do really policy relevant research and end up in the highest impact journals around. So a bit of a sales pitch for those of you who are not doing policy relevant research and maybe thinking that, well, I won't get published in great journals. Well, that's not necessarily true. I think just in the interest of time, I will skip the last few slides and leave you with from that same Trisha Greenlaw article that says, context and confounders lie at the very heart of the diffusion, dissemination, and implementation of complex innovations. They are not extraneous to the object of study; they're an integral part of it. And frequently, those of us trained in clinical epidemiology are trained to strip those things away so that we can say X leads to Y. But the policymaker has the entire alphabet. X and Y never sit in a room together alone. It's always the full system and all its interdependencies. So context and confounders are of integral importance to us. So we need both sides of the equation. We need to know what causes what, so we know what works. But when we go to implement it, we have to think about those contexts and confounders in a different way than which the evidence was generated in the first place. And that's where you get into the implementation science and the diffusion of innovation. And that's why the partnership between researcher and policymaker is so critical. And I will end there, and thank you for your attention.
The terms that are used for health, and there's other terms that you see came out of the communications branch industry, determination of what, how something's called, what something is, have to resonate with the public at large and with policymakers and with politicians as well. I know that, for example, the second panel on cost effectiveness and then deliberating about what the reference case for cost effectiveness should be 20 years ago was the first panel, and they never got traction with the societal perspective. I think a lot of work needs to be done with how to make terminology, make it resonate a little better so it gets traction. But a lot of things need to be liaised with people who do communications as a researcher, more so than has been in the past. And I think that's very key, a very important panel for.
Yeah, all right.
Thank you for that. I think if I can summarize what you said, is you have to think about the system, not just individual pieces of evidence, and I think we're preaching to the converted here. I guess the other thing I would say is, when you showed this first slide about system relevant evidence and patient level relevant evidence, I'm wondering what you mean by evidence. Because, if we think about a lot of people would one of the paradigms we use for the patient evidence was evidence-based medicine. And of course, that values maintain some kinds of evidence. And I just wonder, when you think about evidence, both at the individual level and at the system level, what are you thinking of? Are you thinking costs? Are you thinking values? Are you thinking only randomized trials and meta-analysis? And what are some of those other sort of domains of evidence get used?
Well, I think it's a good question, and I show that slide in settings like this often because there are a lot of clinicians or people trained in that paradigm, and it's to show that, in some ways your paradigm is not that much different. We draw upon similar streams, and I would say the SAC guy at evidence-based medicine paradigm is, it says, if it's not the RCT or it's the meta-analysis, it's, you're devalued. I think that's a quick way to put it. It's like it's a currency that's worth less. Clearly, that's not the case with system level, because when we're trying to figure out, we need evidence of cost. We need evidence of what the people who are going to be the recipients of this service will think, because if it's not acceptable, it doesn't matter if it's going to benefit them. And even that terminology is sort of a utilitarian, technocratic perspective, and that the idea that the government provides services and somebody will accept them as useful and use them. You can't separate them. So that part is critical. So, for our perspective in the branch, I think our best possible study design is the mixed methods, where you're understanding at a real narrative level what the perspectives and values and how the intervention's being used and adapted and reinvented, because that's one thing that's clear from the innovation literature and Tricia law, that any complex innovation is adapted and reinvented and nested within the context of a user's experience or the organization's experience. So those are valuable forms of evidence. It's just they don't tend to show up in published paper. So we have to get that evidence somewhere else. And so I think we take a pretty holistic view of what evidence is. But we're quite clear, at least what we put forward, what comes from a meta-analysis and, what comes from, a modeling exercise. And, we try to be very clear where our assumptions are based and, if it came from another country or whether we just are taking a best guess because nobody has ever talked about the issue before, but now we're needing to.
Just in terms of the types of evidence that policymakers use, this is a bit of a practical question. But as I mentioned, I work for the Canadian Task Force on Preventive Healthcare, and they produce evidence-based clinical practice guidelines for primary care.
Mm-hmm.
And so they do a full, high-quality review of the literature. They look at things like cost effectiveness, patient preferences and values, and then they also look at implementation. I was wondering, would the ministry ever look at something like a clinical practice guideline to influence policy on screening programs or fee schedules?
Well,
is that like a
I mean, we don't. It's a tough one because, I had that schematic that showed that, kind of the macro level uses certain kinds of evidence, but it's not ever pure like that, where, a policymaker would never use a clinical practice guideline and a clinician would never use an ACO article. So I think you'd find, when I was involved with diabetes strategy work, we were looking a lot at practice guidelines to help us figure out what reasonable targets and quality incentives might be. And, the people at Cancer Care Ontario, for example, would be looking at that evidence all the time to inform their screening programs. It all depends on it's more programmatic than systematic, I would say. So I would never categorically say no, but there would be people who would never look at it because it just wasn't relevant to them. They were, strictly focused on organizational or system levels. But, if you're deciding, vitamin D is a good example. That was, that went through OTAC, and we were testing probably in inappropriate ways, and vitamin D had never been linked to any of those things that a lot of people say that deficiency can cause in a primary endpoint. And so it was a nice case where, maybe it needs to have specific criteria. That, you can test somebody for vitamin D deficiency if you have some clinical suspicion that they're deficient, but not because you think that, they are going to improve their odds of not getting patient X by supplementing with vitamin D. So, OTAC said, yeah, you should probably take that off. And then that had to go through that whole process, by the way, because it was a change in the fee schedule. So it's a long-winded way to say that it really depends on the file, the project in the area of the ministry, and what the delivery responsibility of that area is.
Any other questions? Okay, so I guess that's it for today.
Yeah.
Thank you so much.
Oh, thank you very much.
Basil?
Yeah.